Good afternoon, everyone. We will be starting shortly, just letting everyone join. Good afternoon. We will now begin today's webinar. Today's webinar is entitled Call to Action for Building the Home and Community-Based Services Workforce Data Infrastructure. Before we begin, we are going to review some housekeeping items. All participants have cameras turned off and are muted. Participants may submit questions via the Q&A feature. If time allows, we will take questions at the end of today's session. We also have ASL translation and CART available. CART can be accessed within Zoom or using the link in the chat to open in a separate window. Spanish translation via CART is also available through the link. To access CART in Zoom, attendees will need to select the Show Captions button on the bottom toolbar. This will cause the button to change and now read Hide Captions. Click on the caret next to the Close Captioning button. In the menu, make sure the translation toggle is turned off and make sure the My Caption language is set to manual captioning. Please reach out to conference@NCOA should you have any technical issues during the webinar. Finally, the webinar will be recorded and a copy of the slides will be available after the webinar. Today's agenda includes a joint Department of Health and Human Services Administration and Department of Labor presentation on the Home and Community-Based Services HCBS Federal Opportunities Regarding Workforce and Data Research HCBS Forward work group. The presentation will be followed by an expert panel facilitated by the Direct Care Workforce Strategy Center. I will now introduce our first speaker. Mara Carlson joined ACL as the Deputy Administrator of Programs in June 2023. She joined ACL from the administration of the Assistant Secretary for Health within the U.S. Department of Health and Human Services, where she served as a Deputy Assistant Secretary for Health Policy. Mara has worked on a broad range of health policy areas in Congress, HHS, and nonprofits for nearly 2 decades. As the head of OASH Policy and Office of Policy and Legislation, Mara developed and directed policy initiatives on a wide variety of issues and advised the Assistant Secretary for Health on all aspects of legislation, policy, research, evaluation, and intergovernmental matters. Before joining OASH, Mara held a variety of health policy and leadership positions at the Center for American Progress. Prior to joining CAP, Mara was an attorney for the Centers for Medicare and Medicaid Services Division of the Office of General Counsel. I will now turn it over to Deputy Administrator Carlson to begin today's program.
Thank you very much, Laura. As Laura mentioned, my name is Maura Carlson. I am the Deputy Administrator for Programs at the Administration for Community Living, which is part of the Department of Health and Human Services. I am a white middle-aged woman with brown shoulder-length hair with bangs. I am wearing a black top and a blue blazer. Before moving on, I want to first thank the National Council on Aging, who operate the Direct Care Workforce Strategy Center, for hosting this call, as well as for all the organizations that are working with NCOA on the center. I'd also like to thank our colleagues at the Department of Health and Human Services Office of the Assistant Secretary for Planning and Evaluation, ASPE, and the Department of Labor for their leadership on this important call to action and for presenting on the call today. As most of you know, a little over a year ago, in April of 2023, President Biden signed an executive order charging HHS and DOL with identifying gaps in knowledge and data about the home and community-based workforce serving individuals with disabilities and older adults. During the call today, you will hear from ASPE and DOL about how HHS and DOL came together and worked to identify data needed to support the direct care workforce, improve access to these services, and to track the important impact of policy changes over time. This work is absolutely critical because each day this workforce plays a vital role in people's lives by providing necessary supports and services to people with disabilities of all ages, as well as older adults. Their work enables individuals who require services and supports to live in their own home and communities and to participate fully in all aspects of community life. Despite the essential support provided by these professionals, direct care positions often come with low wages, few benefits, and little access to training or opportunities for job growth, leading to a workforce shortage. As demand for direct care workers continues to grow, we recognize that one key to understanding how to improve job quality and expand equitable access to services is through data. Additional data are needed to better understand the workforce and emerging trends, and to quantify linkages between workforce investments and quality outcomes, both for workers and individuals receiving these services. And that's where this call to action comes into play. And now I'm pleased to introduce Tisa Marie Sherry from ASPE and S.J. Glenn from DOL, who will be describing the federal work group and present recommendations to improve data about the HCBS workforce. Dr. Tisa Marie Sherry is the Deputy Assistant Secretary for Behavioral Health, Disability, and Aging Policy at ASPE, and she's also been performing the duties of the Assistant Secretary for Planning and Evaluation since May 6th, 2024. In this capacity, she leads the Office of the Assistant Secretary for Planning and Evaluation, and its role as the think tank for HHS and a policy advisor to the Secretary. She is a health economist and general internist whose research investigates healthcare delivery, financing, and policy strategies to improve the health and economic status of adults with chronic medical conditions, in particular, mental illness, substance use disorders, and disabilities. Sarah Jane, or S.J. Glenn, serves as the Chief Economist at the Department of Labor. She was previously a Senior Advisor for the Department's Women's Bureau. She's a labor sociologist and policy analyst with experience working at the national, state, and local level. Prior to joining the Department of Labor, S.J. spent her career researching and working to advance policies that help support employment and economic security for women and caregivers, including paid family and medical leave, paid sick days, workplace flexibility, and pay equity. And with that, I'd like to turn it over to my colleague, Tisa, and for the next part of this program.
Wonderful. Thank you so much, Maura. And hello, everybody. Thank you for joining today. As Maura mentioned, my name is Tisa Marie Sherry. My pronouns are she, her, and I am a Caucasian woman with dark brown hair wearing a white blazer and with a blue background. I'm delighted to be teaming up with Dr. Sarah Jane Glenn today to share with you the work that HHS and the Department of Labor have jointly led with critical input from our external partners to fulfill the executive order directive charging our departments with reviewing the available data on the workforce delivering home and community-based services, identifying gaps in the data, and issuing recommendations on how to address those gaps. Today, we're going to share those recommendations, which we hope, as Maura mentioned, will serve as a call to action for all of us, the federal government included, also states, researchers, advocates, and all organizations working to improve access to care and supporting the care workforce, to work together to strengthen the HCBS workforce data infrastructure. Next slide, please. To fulfill this charge, HHS and the Department of Labor established the Home and Community-Based Services Federal Opportunities Regarding Workforce and Research Data Work Group, or HCBS Forward, with the goal of ensuring that older adults and children and adults with disabilities have ready access to high-quality, trained workforce that can support their goals of living independently and participating in their community. Also, that the workforce receives family-sustaining wages and benefits and is empowered to advocate for themselves and those they support, and that there is available data to ensure that these goals are being met. Data is fundamental to our ability to ensure access to HCBS and support HCBS workers. Data allows us to determine whether we are meeting the growing demand for these workers, to improve workforce planning efforts, to improve access to high quality services, to inform policies to support these workers, and to evaluate policy impacts. Next slide, please.
Hi, everyone. I'm S.J. Glenn. Like Tisa said, I'm from the Department of Labor, and I am a white woman in my 40s wearing glasses and a black and white striped blazer. Our process as we undertook this project was first to identify and define what we considered the HCBS workforce to be for the purposes of this project. So we're talking specifically here about personal care aides, home health aides, some nursing assistants, and direct support professionals. Our first step was to identify some of the key questions about this workforce so that we could center our data priorities around answering those important questions. For example, we know that there's a growing demand for home and community-based services and that the current workforce will not be sufficient in order to meet our country's future needs. So one set of questions related to different measures of job quality, including wages, but also other workplace benefits like access to retirement plans and paid leave, and how those job quality components connect to worker recruitment and retention. So once we'd identified a set of questions, we reviewed existing data sources in order to identify where there were gaps or other data-related challenges that might impede our ability to answer those questions. We identified options to fill critical gaps, always with a focus back on research and policy. And we gathered input from our external stakeholders, including people with disabilities, older adults and their families, HCBS workers, including those providing self-directed care, unions, disability, aging, and labor advocacy and provider organizations, state leaders, and researchers. We also held a listening session at the Advancing States HCBS conference last August in 2023. Next slide, please. So some of the major gaps that we identified were that the current federal data landscape just doesn't allow us to answer some of the most pressing questions that we have about this workforce. For example, a lack of detailed longitudinal data that follows the same individuals over time makes it difficult to measure the stability of the workforce. And small sample sizes mean that much of the available data cannot be disaggregated by state or by detailed occupation. And the available data does not link workers to the source of funding for the HCBS services they provide. This makes it difficult to study how those providing government-funded services may differ from those who are working under a private pay model, or how self-direction models may or may not lead to different worker outcomes or different outcomes for the individual being served compared to more traditional HCBS agencies. And finally, more detailed data is necessary in order to study how technological advancements are impacting home and community-based services and how successful some of these emerging trends are. Detailed data would also allow further analysis of investments in the HCBS workforce, those happening at the federal, state, and local level, and how those investments impact the outcomes experienced by workers, individuals receiving services, and their families. Next slide, please.
All right, and now I will start in on our recommendations for how to close these important gaps that Dr. Glenn mentioned. The first recommendation is to establish and regularly field a nationally representative survey of the HCBS workforce. We recommend that such a survey be replicated between every 3 to 5 years in order to evaluate the impact of policy changes, follow trends over time, and also ensure that we continue to have timely data to understand future challenges. We recognize that this would be a substantial new effort that would require a significant ongoing source of funding. One of the key challenges to being able to advance this recommendation is that currently there is no national sampling frame that could be used to identify HCBS workers. However, HHS has taken initial steps to help inform the development of such a sampling frame to enable a national survey of HCBS workers. Our colleagues at the National Center on Health Statistics are fielding a pilot study of workers providing services through entities that are included in the National Post-Acute and Long-Term Care Study, or NPALS. These include nursing homes, residential care settings such as assisted living facilities, and adult day centers. NCHS is currently testing a sampling protocol, questionnaire, and contact strategies that could inform a future national direct care workforce survey in the pilot. The survey is intended to be fielded in the entities that are currently included in NPALS, but could be extended to reach the HCBS sector as well. One other thing that we do want to note is the importance of national data collection efforts, including various types of workers and information about the differing skills and challenges that they face. In our conversations with external stakeholders, the need to improve data collections on direct service professionals in particular was identified as critical to informing program planning and state Medicaid rate setting methods. So to that end, ASFE, in coordination with ACL, is conducting research to document definitions and occupational characteristics such as job functions, qualifications, and duties of direct service professionals compared to other types of direct care workers. We will also be convening a technical expert panel in the future to discuss a standard definition of direct service professionals as a foundation to enable more standardized data collection in the future. Next slide, please. Our second recommendation is to establish and consistently field a nationally representative survey of adults with disabilities who are working age, ages 18 to 64, about their need for and receipt of services and supports. This survey we also recommend be replicated every 3 to 5 years to evaluate the impact of policy changes. Now, for older adults, we have very robust data on disability, the need for long-term services and supports, and how these needs are met or not by family caregivers or paid care providers. But we don't have similar data on the working age population, which makes it difficult to understand how much need there is and how much support is provided by family caregivers alone, and how many people suffer with unmet needs. HHS has taken initial steps to inform the development of a national survey of adults with disabilities to capture this information. My Office of ASFE is currently developing a questionnaire that could be used on surveys to understand the need for long-term services and supports, and to identify how those needs are currently met and how much unmet need there is for long-term services and supports. We're also examining the most efficient and robust data collection efforts so that data can be gathered as soon as possible to inform policy decisions. Next slide, please. Our third recommendation is to enhance consistent and systematic state data collection efforts and share evidence-informed best practices of state data collection on the HCBS workforce. Many of the state representatives joining us today are the true leaders and innovators in this area, and tremendous opportunities exist for states to learn from one another and share evidence-informed practices to improve state-based workforce data collections. Lessons learned from states to improve data collection on the workforce will be published on ACL's Direct Care Workforce Strategy Center online resource hub. In addition, HHS has recently taken a number of additional steps to help promote data collection and transparency by states through the Medicaid program. For example, the recently finalized Medicaid access rule includes a number of requirements for states that will advance our understanding of HCBS workforce compensation, payment adequacy, access to HCBS services, and quality. In addition, CMS's Workforce Registries Initiative which was announced earlier this year, supports the development and implementation of direct care worker registries and best practices related to registries. This is an important strategy for ensuring that individuals receiving Medicaid-covered home and community-based services have awareness of and access to qualified workers who deliver services. And critically, it's an important source of data as we assess the availability and adequacy of the workforce. Next slide.
Our fourth recommendation is to maximize our existing federal data resources. Federal data, including that from the Bureau of Labor Statistics and the U.S. Census Bureau, does contain information on the HCBS workforce, and agencies publish data tables and analyses along with public use microdata files. But because microdata analysis, sometimes using statistical software, is often necessary to identify the HCBS workers within the data, this can limit its reach. As a result, HHS and DOL are taking steps to make sure that the existing data on the HCBS workforce is more readily available, both to researchers, policymakers, and others who are interested. Next slide, please.
Thank
Sorry.
you so much. Sorry, SJ, I was taking a second to come off mute there. Our fifth recommendation is to maximize the existing administrative data sources to provide information on the HCBS workforce. So administrative data and Medicaid claims data in particular may be a significant resource for data on the HCBS workforce. But these data have not been analyzed fully to understand data on employers and workers providing HCBS. In ASPE, we are undertaking exploratory research using TMSIS, Medicaid claims data, to understand whether HCBS are provided primarily by agencies or individuals, and to identify which occupations and types of agencies make up this workforce. And this will help us better understand the extent to which Medicaid claims data can be used and optimized to identify providers claiming for HCBS. Next slide. Finally, we recognize that these recommendations are ambitious and they require collaboration. We in the federal government are eager to partner with you all in this work and to learn from all of your successes. So we'll close our presentation today by describing some forthcoming federal resources to advance this work, but we recognize that this is a start and we have more work to do together. The first resource is ACL's Direct Care Workforce Strategies Center website, which serves as a centralized source for federal data on the HCBS workforce, new publications, and updates from the field. On this website, our HCBS Forward Workgroup products are available, including our issue brief, which describes in more detail the recommendations that Dr. Glenn and I discussed today. An additional forthcoming resource is that ASPE and HHS will be replicating and updating a study that we published last year examining the wages of direct care workers compared to the median wages of other entry-level workers, both nationally and state by state, using more recent data. And I'll turn it over to Dr. Glenn to finish us off.
Thank you. We're also planning to release the HCBS Forward's data source information table, which contains a lot more information on the existing data sources that include information about the HCBS workforce. Additionally, the Bureau of Labor Statistics is planning to spotlight data on home health aides and personal care aides by publishing summary tables and summarizing data in their reports, Spotlight on Statistics, and Commissioner's Corner publications. And finally, the Department of Labor will publish new analysis comparing the pay of care workers, which includes home care workers along with early childhood care providers, and comparing their pay to the pay of other workers who've been identified as having similar workplace requirements, duties, skills, and training. Thank you all so much for your time. And now I'd like to hand the mic back to Stephanie Gibbs, who will be moderating the facilitated portion of today's conversation.
Great. Thank you so much, Dr. Glenn. And thank you for sharing those enlightening findings and recommendations from the research. I'm Stephanie Gibbs, and I'm the director of the Direct Care Workforce Strategy Center at the National Council on Aging. The center is funded through the Administration of Community Living. Before we get started, I will offer a description of my visual presence here today. I'm a middle-aged white woman with brown hair, glasses, and I'm wearing a black blazer. Now to introduce the panel for further exploration of the key points shared through the presentation. Chris Dula has served the state of Washington for 7 years as an expert in qualitative and quantitative research methods, with an emphasis on workforce program and policy evaluation. Chris received the Congressional Award for his national service as a former AmeriCorps and Peace Corps Thailand volunteer. He holds a Bachelor of Economics from Metropolitan State University of Denver and a master's specialized in advanced policy and economic analysis from Columbia University. Chris has over 15 years of professional experience in government and academia. His work as a researcher for Singapore Management University has been published in the Harvard Business Review and Financial Times. Dr. Amy Hewitt has an extensive background and work history in the field of intellectual and developmental disabilities and has worked in various positions over the last 30+ years to improve community inclusion and quality of life for children and adults with disabilities and their families.
At the University of Minnesota, she is the director of the Institute on Community Integration. Dr. Hewitt directs several federal and state research, evaluation, and demonstration projects in the area of community long-term services and supports for children and adults with intellectual and developmental disabilities. Dr. Hewitt has authored and co-authored numerous journal articles, curriculum, technical reports, and she has co-authored books entitled Staff Recruitment, Retention and Training, and Critical Issues in Intellectual and Developmental Disabilities, Contemporary Research, Practice, and Policy, and a soon-to-be-published book called Community for All, Community Living and Participation for Individuals with Intellectual and Developmental Disabilities. And then finally, Sean Sloan is a senior policy analyst at the Council of State Governments, where he leads a project on the long-term care workforce in partnership with the Commonwealth Fund. Initial work resulted in the publication of a long-term care policy guide, and he has worked with states to provide technical assistance on long-term care workforce challenges. He also leads the development of the Council's agendas for annual Medicaid Policy Academies, which bring together state legislators and executive branch officials to discuss the latest in Medicaid policy. In recent years, he oversaw 2 projects on mental health policy and staff subcommittees on leveraging innovation in healthcare and the workforce of tomorrow. He has a master's degree in journalism from Northwestern University. And we thank our distinguished panel for joining us today. Okay, for the first question, we come to you, Chris. We heard our federal partners describe the importance of a data infrastructure to inform both home and community-based service availability for older adults and people with disabilities, and the direct care workforce who support these services. Washington State embarked on a cross-system initiative described as a partnership of labor, government, business, and nonprofits. Can you describe Washington's workforce initiative, including any key partnerships and the state's approach to direct care workforce development?
Absolutely. Thank you, Stephanie. First, to describe myself, I am a 40-year-old white man wearing glasses, closely cropped facial hair, and have a large nose. Before I sort of start talking about the Workforce Training and Education Coordinating Board's involvement in the long-term care workforce initiative, it really begins around 2017 with the Washington Nursing Board investigating and working together to come up with solutions to the direct care workforce crisis. Multiple iterations of that initiative up through about 2020 culminated in a recommendation to the state legislature to pass on this workforce-related work to Washington's Workforce Board. The reason for that is because there are so many different players and moving parts that are part of the long-term care ecosystem. And the Workforce Board, because of its unique construction, seemed to be a better fit for managing such an initiative. So Washington's Workforce Board, or Workforce Training and Education Coordinating Board, is a unique tripart body of government, industry, and labor, where we have a co-chair of both industry and labor. We are also authorized as a small small executive office to lobby on behalf of recommendations of the board to the state legislature. So we're an ideal platform to bring together different voices to come up with policy recommendations, resulting in different bills and changes in policy. Within the government side of the board, we have pretty much all of the different agencies that have some part of managing the long-term care workforce. So the Department of Health, our secondary education system, post-secondary education system, the Employment Security Department, the Department of Social and Health Services. And so this gives our organization a chance to understand what's going on with all these different agencies and to collaborate. So in 2022, the long-term care initiative was established and to be managed by the Workforce Board. And the long-term care initiative is my primary portfolio. And what we have succeeded so far in doing is every year we produce a report that goes to the state legislature, which includes a number of recommendations to address the long-term care workforce crisis. But we have a group of around 200 different stakeholders that not only represent say government actors, but also employers within the long-term care sector, and most importantly, the workers within the long-term care sector. And so all of these voices come together and we're able to collaborate closely on putting together recommendations. So that is I feel a fairly unique solution to being able to build out solutions. And part of that is data-driven solutions. And because all of these different agencies, especially, and employers, workers, they all have different information that can come together. And so we are able to bring that information together, synthesize it, and provide the empirical backing, but also some of the anecdotal backing of recommendations that come out of our initiative.
Great. Thank you so much for that, Chris. And just to stay with you for a moment, I'm anticipating questions from the audience, especially some of our state partners who may have tuned in today. So as a researcher, can you share a little bit more specifically about how your role supports the efforts of the Workforce Training and Education Coordinating Board that you mentioned convened there in the state of Washington?
Sure. So right now we have a partnership with the University of Washington Center for Health Workforce Studies. And they analyze the PBJ data from CMS, which just really just gives you information on skilled nursing facilities. But there's a lot of other actors within long-term care. So they are also doing purposive sampling of direct care workers, including home care aides, to better understand their needs and understand a lot of the conditions that they're facing. So as you know, there's a dearth of data here. We do have some information in Washington. So for example, the Department of Health licenses home care aides. Washington State requires home care aides to receive recognized credentials by the Department of Health, which become licensed, so we do get counts. But we have also been able to, we have data sharing agreements with different state actors, such as Employment Security Department. So in 2020, we advocated and were able to help support legislation. I think it was House Bill 2308, which requires employers to report on standard occupational codes for all of their covered employees, and also their own industry codes, like the NAICS codes, right? So we can get very detailed, we should be getting 2025, very detailed information as to specific counts of workers, which include home care aides, within different areas of Washington and within specific industries, so we can get a better sense if they're working within a home care agency or assisted living facility. So this goes beyond just the skilled nursing facilities, which are covered by CMS data. And so in terms of my role and the research unit within the Workforce Board, we have access to the data and we're able to analyze it, model it, and be able to provide empirical evidence which supports our advocacy work for lobbying, regulatory changes, and also supporting different bills being sponsored in state legislature.
Thank you for that, Chris. So now we'll turn to Dr. Hewitt and to Sean. Based on your experience working with various states, can you please share some of the innovative tactics and strategies you've seen states roll out recently to collect and analyze data to better understand direct care workforce trends, including utilization and quantifying workforce shortages, and also understanding supply versus demand? So Dr. Hewitt, we'll come to you first.
Thanks, Stephanie. I'm Amy Hewitt, and I am a white female, newly anointed 60-year-old as of a day. I'm getting used to that. And I have long brown curly hair and am wearing a multicolored shirt. As I think about this question, I'll reflect on three things that come to my mind. The first one is it's really nice to see more and more states using the National Core Indicator state workforce data collection. Their 2022 report on the intellectual and developmental disability side had 29 states participating. And I know that there's a parallel effort going on the aging and disability side of NCI's work, and they're working on a version for self-direction. So I think the more we can get states using the same tool, or at least the same measures we have in the same timeframes, we have a much better chance of getting closer to a national picture of staff stability in this space. What it allows us to do is to offer individual states national comparatives or national benchmarks that they can compare to. We've done a fair amount of work the last several years in the state of Rhode Island, and data was a big part of, from the very beginning of their workforce development statewide initiative, and wanting to be able to quantify whether some of the interventions they were trying worked or didn't work. And so they have been using a data portal called SupportWise, which we created here at the University of Minnesota. And they collect data, standardized data from 100% of their employers. They actually have 100% response rate every 6 months. And one of the unique benefits is that the employers have real-time access to their own data. There's no wait time. They have real-time access to it. They have a dashboard that identifies their data, and they can look at that data in multiple ways and compare it to national benchmarks when available. So I think that is, and what we see, there are two examples that I see. So their turnover rate is pretty low compared to most states, but their percentage of their workforce that leaves early and are terminated is quite high, far exceeds any national benchmark. And so we've really worked with them to focus their intervention work on selection processes that will reduce the likelihood you're going to terminate somebody. So it's just one example in that state of how the state system is using this more precise data to get at interventions that will reduce turnover and vacancy rates. They also are working it's been a real interesting process to get people who use self-direction to see themselves as employers. And so the language that we've been really focused on in that state is employers versus organizations or self-direction, because people who self-direct are employers and have to hire and support people who deliver direct support to them. So that's been a real focus there, and being able to look at the data, looking in self-directed services versus other services, I think will be really helpful. We also, and Stephanie knows this, for a long time, we've done some work in Tennessee, and I think there's some unique things about that work related to data. Again, they've been collecting data for quite some time. They collect it across population groups within HCBS, and they were one of the very first states to require the managed care entities that they work with to build in workforce data collection. So we started doing data collection for them at the state level. Now we do it through managed care entities, and those entities working together, again, through kind of, in that state, we've still been at electronic survey, but not using any kind of a portal that automatically does the analysis and spits out the findings. The providers there receive a summary profile of their key workforce metrics that they use to identify interventions at that organizational level. And then looking across all of those, the managed care entities can come up with strategies for their intervention work. One of the things that we also do in that state is a regional data summary and regional profile, because that was important to the state. So those are just a few examples of the different ways people are gathering the data, but importantly that all of them are using that data to try to help solve problems specific to their circumstance, because all turnover is not the same. All vacancies are not caused by the same thing. And you have to get at that precision level at the organization employer level to make the change.
Thank you, Dr. Hewitt. Now, Sean, we'll come over to you for your perspective.
Stephanie, thank you so much, and good afternoon, everybody. I'm Sean Sloan. My pronouns are he, him, his, and I'm a white 56-year-old male with black hair, and I'm wearing a cream-colored shirt and brown tie, and I wear glasses. I see a lot of familiar names amongst the attendees, but for those who haven't been aware of what we've been up to over the last couple of years at the Council of State Governments, starting in 2022, CSG has had an ongoing project supported by the Commonwealth Fund to identify state initiatives and in some cases, local initiatives to improve long-term care. We had an 8-state task force in 2022 that helped guide us in the development of our long-term care policy guide, which highlighted 3 focus areas. Those efforts to optimize those ARPA HCBS investments, state regulation of nursing homes, and revitalizing the direct care workforce and supporting family caregivers. Last year, we spun off the 3rd of those focus areas into its own project. We expanded our 8-state task force into a national network that now includes not only state policymakers and staff, but folks from a wide variety of organizations and stakeholder groups. We began hosting monthly webinars focusing on a different aspect of the long-term care workforce or a different set of strategies that states were deploying. We've actually got our next meeting today at 3 p.m. Coincidentally, Camille Dobson and April Young from Advancing States are going to join us to talk about the recent report on lessons learned from the whole ARPA HCBS process, especially the workforce-related initiatives, as well as the intensive TA that the DCW Strategy Center and its partners are going to be providing to states in the months ahead. So once I shut up here in a minute, I can add the link in case any folks want to sign up for that and join us this afternoon to continue the conversation on HCBS. We too at CSG have had the opportunity to provide technical assistance to public officials as they have worked to develop long-term care policies. Earlier this year, I spoke to the Illinois House Human Services Committee as they consider what comes next after the nursing home rate reform legislation that was passed a couple of years ago. I was also in Hawaii in February. They were one of our task force states in 2022, and we have stayed in touch with them since. They had an ambitious legislative agenda that they were considering this year and have had some significant successes during the session. We also have been working with some folks in Bucks County, Pennsylvania, to put together a meeting next month during which folks will hear about various revitalization strategies that can be deployed at the local level. So for us, our technical assistance has involved briefing policymakers on our state strategies to revitalize the long-term care workforce, including not only the initiatives that were in our policy guide, but also some that we've turned up in the months since it was published. Those strategies and updates are explored in our long-term care policy website, and I will add a link to that in the chat here shortly as well. Spoiler alert, one of those state strategies is data collection and monitoring. As we noted in the policy guide, a number of states have taken those initial steps to improve direct care workforce data collection. Knowing more about the volume, stability, and compensation of the workforce can help policymakers quantify concerns, identify priorities, implement solutions, and evaluate outcomes. Policymakers can look to state agencies and various professional and academic organizations that collect workforce data. Some of the examples of state initiatives we highlighted in the policy guide were California's Data Dashboard on Aging, which has tracked the number of direct care workers by type and tracks licensed workers per 1,000 older adults by county. Massachusetts required the creation of a public registry for home care workers in its state home care program. The registry verifies the type of training received and credentials earned. Then some more recent examples that we have on the website. Arizona's ARPA spending plan proposed an investment in the workforce data reporting system to help state agencies monitor trends affecting recruitment and retention of the healthcare workforce. New Jersey established the Alzheimer's and Dementia Care Long-Term Advisory Commission, which will report about the state's long-term care facilities capacity and evaluate the sufficiency of the state's dementia care workforce, including identifying current and future workforce needs, anticipating future workforce shortages, and developing innovative strategies to encourage and increase the recruitment and retention of workers. Pennsylvania directed the Legislative Budget and Finance Committee to conduct a study on the effects of workforce shortages on state-supported Medicaid HCBS waiver programs and area agency on aging programs. And our friends in Wisconsin told us the University of Wisconsin Green Bay collects demographic information on individuals who complete their certified direct care professional program. So lots of things that states have been working on in terms of trying to understand who this workforce is, what their needs are. But it's not just figuring out what the baseline looks like in terms of the state of the direct care workforce that can tell us the kinds of workforce strategies that are needed. It's not just, are there enough people to fill those roles who aren't taking jobs at McDonald's instead, but where do they come from? It's about the quality of care and reducing inequities of the system and improving health outcomes and increasing efficiency.
Great. Sean, thank you so much for that. And please do post those links in the chat.
Will do.
For our guest. And also, as I'm looking at the chat, I'm seeing some real live connections being made in the state of Washington, and that's exactly what we intend. So that's great. Please do utilize the chat for that way. In that way. Okay, so Dr. Hewitt, we'll come back to you now. For states who are just starting to revisit their data collection processes, what are some key criteria states should consider in developing new surveys and other methods for collecting data on the workforce?
Sure, thanks. So some thoughts I have are just actually pretty basic, but I see so many times that these things are forgotten. So upfront, really knowing what you're going to use the data for and who your stakeholders are. And the more you engage the people who you want to fill out that survey, so whether that's self-directed employers, organizations, or the people who do the work, you're going to have much greater luck if you involve them in the development process and in the implementation process. So in the state of Rhode Island, when the state sent out surveys related to the workforce data, they didn't necessarily get very high response rates. When we started doing what we called data boot camps and really taught the people who were in human resources or in finance at that local provider and employer level, what the data elements we wanted were, our response rate went way up, and we just had much more engagement and interest in what we were doing. So I think that's a really critical piece. And then the other piece is so often, and I'll use Rhode Island as an example again, where they were collecting all this data but not doing anything with it. So it wasn't very useful. Getting the data so that it can be available real time to the people who are going to use it, I think would be ideal. Hard to do, but ideal. And then actually sharing the results broadly. That's a step that is so often forgotten. And now you can show people, look, we've done all this work around training and education or around marketing and recruitment, whatever the work is. And look, here are how our numbers are trending. Just sharing the results of it gets people more enthusiastic about staying engaged for the long haul, because everybody wants one single answer and they want the solution to solve the problem right now. And these are decades-long interventions and solutions. And so keeping people engaged from the very beginning and making sure that whatever they're providing you related to data is being used and they understand how it's being used, I think are two of the most critical things. And then the last thing is there is a lot of overlap in this workforce and what they do and the competencies and skills required, but they aren't exactly the same workforce. And they use different words. And that's why that stakeholder engagement is so important up front, because your data may be very skewed just because they don't understand a single word in one of the most important questions. So making sure that vocabulary is agreed on and there's understanding and definition around that vocabulary is critical.
Thank you so much, Dr. Hewitt. So Sean, we'll come back to you now. Several state ARPA plans focus on increased investments to improve training opportunities and to develop career ladders and lattices for various direct care workforce professions. What are some of the important key learnings you've observed in states that could serve as key criteria for states who are continuing to develop their training and career pathways and initiatives for these critical direct care roles?
Yeah, so the two relevant state strategies that we have in our policy guide and on our website are enhancing training and education and facilitating career advancement. And there's some overlap between those two things. But on the first one, we see an emphasis on not only trying to increase training requirements, but incorporating competency-based training that addresses the full range of skills required for jobs as CNAs and home health aides and so forth. A number of states, including Arkansas, California, Colorado, DC, Florida, Georgia, Illinois, Indiana, Kentucky, Montana, Oregon, Pennsylvania, Texas, and Virginia have addressed dementia care training requirements in recent years. In 2022, Idaho appropriated $5 million for job training and apprenticeships for in-demand professions, including key dementia care roles such as CNAs, medical assistants, LPNs, and RNs. States are also addressing the education side of the enhancing training and education piece. Minnesota provides scholarships and student loan repayment for nursing facility staff, including nursing assistants. Mississippi provided short-term tuition, vouchers, and healthcare credentials to unemployed and underemployed CNAs. The Tennessee Quilts program, we have a few folks on from Tennessee. It's a value-based payment program allowing direct care workers to earn a series of competency-based micro-credential badges, earn college credit, and advance along clearly articulated career pathways. And we heard a lot about Washington. Washington requires 75 hours of entry-level training, along with 12 hours of continuing education for personal care aides to prepare individuals working in all long-term care settings as universal workers. And we've seen other states, Michigan, New York, and Wisconsin, have also explored this concept of the universal aid. Washington has also appropriated funds to create a telemedicine program to disseminate dementia care best practices to primary care practitioners using the Project ECHO model. And we, some of us know what that is, but Washington established a home care aid to a licensed practical nurse apprenticeship pathway pilot program as well. Wisconsin has the Caregiver Careers program to recruit, train, and provide wraparound supports to nursing assistants, and they're implementing a geriatric career development program. Wisconsin also implemented the Certified Direct Care Professional Training Program last year. And the other state strategy relevant to the question is facilitating career advancement. On our website, you can see the slides from the webinars that we did last year on building career pathways and expanding career pathways, and find a lot of great examples of career ladders and career lattices and how states are exploring the development of those. Our friend Natasha Bryant at Leading Age told us on one of those webinars that the reasons for the current workforce challenges are not just inadequate compensation and benefits and poor working conditions, but a lack of standardized competency-based training requirements and a lack of career mobility. In the policy guide, we note that professional caregivers in long-term care settings often face flat organizational structures that offer limited career advancement. Promoting advancement opportunities could allow workers to take on advanced caregiving roles, become mentors for newer workers, serve as part of effective integrated care teams, and perform supervised health maintenance tasks. Direct care professionals in particular need access to career ladders, which can be built with both clinical and social work focuses. Some state examples that we ran across, Arizona's plan for spending ARPA funds highlighted initiatives to develop and implement a formal credentialing process for direct care workers and a caregiver career development pathway. Delaware provides CNAs with an opportunity to become senior CNAs. Florida provided a path for CNAs to become qualified medication aides in nursing homes. Hawaii created a glide path, earn and learn cross-sector collaboration that allows working individuals to maintain their jobs while advancing health education credentials. And finally, in Massachusetts, supportive home care aides, as the title is called, can specialize in caring for individuals with mental health conditions or Alzheimer's disease and other forms of dementia. They are also integrated into care teams. So just some of the many examples that you can find on our website.
Thank you so much for that, Sean. And Chris, we'll come back to you now. So we heard Sean describe training and career efforts in other states and noting some of those efforts in Washington state as well. So to capitalize on Washington's momentum, what can you share about the next iteration of the Direct Care Workforce Initiative? And just to tag on another question there that I'm seeing in our question and answer submission here, what are some promising practices that you could also share from Washington's experience for other states who may be interested in doing something similar?
Thank you, Stephanie. And first, thank you, Sean, for shouting out our CNA to LPN apprenticeship program. Our first cohort has recently completed or is completing this semester their prerequisites to enter into classes for the LPN portion. So the pilot is really officially kicking off this fall. And so continuation of the long-term care initiative, which has that apprenticeship within its portfolio, is essential. These participants have taken a pretty big risk in participating in this type of pilot program. Washington, in this initiative, is committed to creating viable career pathways for direct care workers as a respected part of the entire healthcare ecosystem. And so making sure that we have resources committed to this pilot and seeing it be scaled up across the state is essential to professionalizing this workforce and to creating these viable career pathways. One thing that I would argue is important for the continuation of this work is that it does continue. As Amy said, it is a decades-long process, and so we'll be advocating to the state legislature to at least continue funding for the LTC initiative through 2030, so that we can continue to bring together and convene these stakeholders and advocate for the work we are doing. One of the longer-term goals we would like to do is to establish baseline data collection in regards to things like turnover rates with specific roles and settings, so that we can start evaluating what kind of impact our policies and programs are having on improving the direct care workforce. In addition, we have a pretty substantial backlog of home care licenses, up to a 6-month wait for home care aides to get credentialed and licensed within Washington. This is an echo from the pandemic, and the work that we have done has helped increase the funding for the number of testers. We're also looking at exploring different regulatory change to allow for mobile skills testing, so that we can better expand the direct care workforce within more rural settings in Washington. So just increasing accessibility to training, credentialing, and licensing across the state. And so being able to continue that work is important, and it's going to take time. This is there's a lot of bureaucratic momentum to overcome, a lot of change that has to take place. And a lot of this change is social in terms of how we respect direct care workers and how they fit into the overall healthcare ecosystem. And so part of the work of this initiative is to expand, that level of respect that these workers deserve. And so, how can we make direct care work an attractive destination for people to pursue a career in healthcare? And so, that effort is going to take some time.
Great. Thank you so much for that, Chris. And just in our last moment together, I wanted to mention a question that we have from the Q&A. If I'm a family caregiver or a direct care professional, what advice would you share about becoming more involved in state efforts to support direct care? So very quickly, if we have one panelist that maybe wants to give some advice for folks who want to get a little bit more involved at the state level.
Stephanie, this is Amy. I'm happy to share one idea. And I think the biggest thing is the voice of the people who do this work needs to be heard by elected officials and policymakers. Far too often, it is state agency staff and employers who are doing that advocacy. And I think the extent to which we can teach and support people who are doing this work and allow them time to develop their stories and get them to elected officials, it's going to take that to get the legislation passed at the state level or at a federal level that we all know needs to pass.
Thank you so much for that, Amy. So we've come to the end of our webinar and our time together. I want to say thank you to our panelists for sharing your expertise, and thank you to all of you for tuning in and for all of the ideas and information that you shared in the chat. We'll take a look at the chat. I apologize that we didn't get to all the questions, but we will be able to look at what you shared with us and leverage that information to inform future webinars as well. So thank you to everyone, and this concludes our webinar.
Thank you.
Thank you.